Welcome to the Public Health Practice Gap. I am your host, Dr. Bradley Fevrier. Today, we are going to confront a quiet, administrative disease that is paralyzing our health departments, our clinic, and our non-profits. It is not viral. It is not bacterial. You won't find it in any medical textbook. I call it the navigation fallacy. The navigation fallacy is the comforting, high bureaucratic delusion that as long as we publish enough information, print enough brochures, design enough beautiful websites, and release enough comprehensive resource portals, we have somehow solved the problem of community care. We have not. We have simply added more paper to the maze. To understand how insidious this fallacy is, I want to take you back to our park bench. My daughter and I had just survived the 90-minute fast lane queue crisis, which, if you caught last week's episode, you already know was its own ordeal. We sat down to catch our breath. That was when she reached into our bag and unfolded a giant sprawling piece of paper, the amusement park map. If you have ever looked at a modern theme park map, you know it is a marvel of graphic design and information density. Color-coded pathways through themed plazas, primary and secondary legends, warning symbols for height restrictions, tiny illustrations for everything from restrooms to first aid stations. To me, a researcher trained to analyze complex datasets, the map looked perfectly logical, organized, and comprehensive. But to my 5-year-old daughter, it looked like an absolute terrifying chaos. She stared at the overwhelming grid of colors and symbols for a full minute, her eyes darting from one corner of the page to the other, completely paralyzed. Then she let out a sigh of pure exasperation, looked up at me and asked, "Daddy, why don't they just make it easy to find where we are?" That question hit me like a physical blow, because she was not critiquing the amusement park's graphic design. She was diagnosing the core user experience of the modern American healthcare and social safety net system. She was describing our maps. We tell ourselves that because we have mapped out the system is navigatable. We print the brochures, we upload the PDFs, we build the databases, and when the community fails to find their way to our resources, we write them off as hard to reach, non-compliant, or unmotivated. Today, we are going to tear down the navigation fallacy. We are going to examine the professional bias that blinds us to systemic complexity, calculate the actual cognitive tax we impose on patients in crisis, and then get to what I believe is the real public health frontier, investigating in the human infrastructure of relational navigation. Let's get in. Let's start with what I call the map maker's bias. As public health educators, clinic administrators, and healthcare executives, we spend years, sometimes decades, studying the healthcare map. We know how the pathways connect. We know the mechanisms of primary care referrals. We know the difference between private insurance, Medicare, and Medicaid. We understand sliding fee scales, federally qualified health centers, behavioral health integrations, and county social services. We look at our operational flowcharts. We look at our organizational maps, and we think, this is straightforward. If someone needs help, they just need to look at the chart and follow the lines. But here is where our professional bias completely blinds us. We are consistently mistaking our familiarity with the system for the system's ease of use. We forget that we are looking at the map with the eyes of the cartographer. We design the lines, we build the intersections. The patient is not a map maker. The patient is a lost traveler, often dropped into the middle of the dense forest in the dead of night, while a crisis is actively occurring. Let me talk you through a real-world, ground level journey so you can see what our map actually looks like from the outside. Imagine a parent living in an unresourced neighborhood. We'll call her Jane. Jane works 2 hourly wage shifts to keep food on the table. She does not have a college degree. English is not her primary language. She does not have a reliable vehicle. Yesterday, her 7-year-old was diagnosed with type 1 diabetes. To the clinical executives in the boardroom, the map for Jane is clear. There is a patient portal. There is a discharge docket. There is a referral directory. But let me walk you through Jane's actual next 48 hours. First, who does she call? The discharge paperwork says she needs to schedule a follow-up with a pediatric endocrinologist. She is handed a list of 12 specialists. Second, she has to verify coverage. Jane calls her Medicaid managed care plan to find out which of those 12 endocrinologists is in her network. She sits on hold for about 40 minutes during her 30-minute lunch break, listening to automated elevator music before being transferred to 3 different departments because the first 2 operators couldn't understand her question. Third, she hits the waiting list. She finally finds an in-network provider. When she calls to schedule, the receptionist tells her the next available appointment is 3 months away. Her child needs insulin management right now. Fourth, she navigates the supply chain. At the pharmacy, she is told the specific glucose monitor on the prescription requires a prior authorization from her insurer. Jane has no idea what a prior authorization is. To her, it simply sounds like a polite way of saying no. Fifth, she has to address the food environment. The clinical nutritionist told her to radically adjust her child's diet. The only grocery store within 3 miles of her apartment is a corner bodega that does not stock fresh produce or low glycemic foods. Every single step in that journey is a potential point of failure. If Jane can't navigate the prior authorization, if she gets discouraged by the 3-month wait, if she can't arrange transportation across town, her child ends up back in the emergency department in diabetic ketoacidosis. And when that happens, what does the clinical system do? They write non-compliant on her child's medical chart, publish papers about the low health literacy of under-resourced populations. They blame Jane for not following up. They blame Jane for not following the map. But the map was never designed for Jane to succeed. It was designed to satisfy administrative checklists and protect institutional silos. We have built a healthcare ecosystem that requires a PhD in bureaucratic navigation just to access basic preventative care. So how do we, as an industry, respond to this complexity? We do what institutions always do. When they don't want to change the underlying architecture, we publish more maps. If patients are confused, we design a slicker brochure with high-resolution photos of smiling families. If the community doesn't know where to find mental health services, we launch a new online resource directory with hundreds of links and drop-down menus. If a school district is struggling with child obesity, we print a 50-page wellness toolkit and mail it to the principals. But we have to understand a fundamental mathematical and behavioral reality. Information is not execution. Think about it this way. If you write out the systems level equation for a community member's ability to act on a health decision, it looks something like this. Execution equals information minus friction. Your community's ability to execute a healthy choice is not determined solely by the volume of information you have at hand. It is determined by the information they receive minus the structural and cognitive friction required to act on that information. When you hand an exhausted and stressed traveler a 50-page map, you are not reducing the friction, you are increasing the cognitive load. In behavioral economics, we know that poverty, trauma, critical illness, and systemic insecurity are not just financial crises. They are bandwidth crises. When a patient is calculating how to pay rent, how to keep the lights on, how to stretch a food budget, or how to keep her children safe, her cognitive bandwidth is extremely consumed by survival. She does not have a spare mental RAM to navigate a clunky online portal, translate clinical jargon, or cross-reference resource lists. Handing Jane a brochure on diabetes management whilst she is in the middle of a housing crisis is an administrative insult. It assumes the obstacle in her life is a lack of knowledge, rather than a system built with high friction barriers. We must stop treating information delivery as an active public health intervention. If your program requires a client to print out 3 forms, get them notarized, mail them to an agency, coordinate 2 bus transfers, and wait in a waiting room for 3 hours to confirm eligibility for a food voucher, your program is not accessible. It is a high friction obstacle. The most vulnerable people in our communities do not need shinier maps. They need a system that minimizes friction and maximizes human support. We are going to take a quick break. When we come back, we'll look at the cure of the navigation fallacy, why the most resilient communities in the world don't have the most resources, but the most integrated resources, and how we begin investing in the human infrastructure of relational navigation. But before that, I want to take a moment for something a little different, a personal one. Everything we have talked about so far, the cognitive overload, the high friction barriers, the moment a family hits a wall in crisis, does not only happen in a clinic waiting room and Medicaid call centers. It happens at a bedside. It happens when a family member has just received a devastating diagnosis and someone hands them a thick packet of clinical information at the exact moment their capacity to process anything is at its lowest point. That gap is part of what compelled me to write my new book, When Treatment Can No Longer Cure, A Christian's Guide to Compassionate End-of-Life Decisions. It is a practical, faith-centered guide through the decisions that families face when medicine can no longer promise a cure. Written not for clinicians, but for the people sitting in those rooms, for the patients, for the caregivers, and for the faith communities surrounding them. If you know someone navigating a serious illness right now, or if you want to be prepared before you need to be, you can secure a copy of this book. Also, if you're listening to this and nodding because you have seen these broken maps in your own work, you are exactly why I founded the Next Gen Public Health Lab. For weekly, sharp systems insight in how we close the implementation gap, join thousands of industry leaders by subscribing to my free newsletter. If you are just joining us, we spent the first half of this episode deconstructing the navigation fallacy, the widespread bureaucratic delusions that publishing enough information somehow solves the problem of community care. Now let's talk about the cure. If shinier maps, thicker toolkits, and more elaborate digital directories are not the answer, then what is? The answer lies in shifting our investment from informational infrastructure to human infrastructure. In public health, we are obsessed with physical and digital assets. We write massive grant proposals to build new clinical wings, purchase high-tech diagnostic equipment, or develop proprietary software applications. And those assets have their place. But we consistently starve the most critical asset class in the entire ecosystem, the human beings who actually connect the pieces. Right now, almost every interface in modern healthcare is transactional. Here is a systems level equation I want you to hold on to. Functional capacity equals resource availability times trust. Look at the relationship carefully. It is multiplicative, not additive. If you have $1 billion worth of clinical resources on your map, but the level of trust between your institution and the community is 0, your functional capacity is 0. You can print all the brochures you want. If the community does not trust the map maker, they will never walk the path. So how do we build trust? We do not do it with a website. We do it with people. This is the power of the community health worker. A community health worker is not just an administrative assistant with a neat title. They are the human bridge. They come from the communities they serve. They speak the language, not just literally, but culturally, historically, and emotionally. They know which bodegas are safe. They know how the bus routes actually run on a rainy Tuesday morning. They know the deep historical reasons why a family might be terrified of walking into a sterile clinical lobby. When Jane is handed the list of 12 pediatric endocrinologists, she does not need an automated text message reminding her to call them. She needs a pen navigator. She needs a real human being who can sit down with her, hold a cup of coffee and say, I know this list is overwhelming. Let's look at it together. I know Sarah who works on the food clinic on this list. She's wonderful with kids. Let's make this call right now. And while we're on hold, let's figure out how we could get you a ride there. This is not information delivery. This is relational navigation. And it is the only form of navigation that actually closes the implementation gap. And the data backs it up. A major health affairs study found that every single dollar invested in community health worker interventions returned $2.47 to Medicaid payers within the same fiscal year. $2.47 on the dollar within 12 months. When we invest in people, we work alongside communities. We are not just being compassionate. We are being economically rational. To scale this model, we have to fundamentally redesign our operational workflows from a transactional architecture to a relational architecture. Right now, almost every interface in modern healthcare is transactional. A patient walks into a clinic and we perform a transaction: intake, billing, clinical measurement, a prescription. A patient needs a specialty care and we execute a transaction. We hand them a referral slip with a phone number, print a clinical summary, and check a box in our electronic health record saying referral complete. We evaluate our staff based on transactional volume. How many patients did you see today? How many brochures did you hand out? Under a transactional architecture, the burden of execution is entirely pushed onto the patient. The system washes its hand of the outcome the moment the referral transaction is recorded. In a relational architecture, the primary unit of value is the warm handoff. A referral is never a piece of paper or an automated email. A referral is a trusted transfer of relationship. In a relational system, when Jane's primary care provider determines that her child needs to see an endocrinologist, the protocol does not end with a printed slip. It begins with an active connection. The clinical navigator says, Jane, I'm going to walk you across the hall right now to meet Elena. Elena is our care coordinator. She works directly with the endocrinology clinic downtown. She's going to be your partner over the next 48 hours to get this appointment scheduled, get your Medicaid coverage confirmed, and make sure you have the insulin supply before you leave the building. Look at what happens to systemic friction in that moment. We have physically and emotionally absorbed that friction on behalf of the patient. We have taken the cognitive load of navigating a complex multi-tiered Medicaid system and transferred it to a trained professional whose entire job is to handle that complexity. This is not a luxury. This is high utility systems engineering. If we can invest millions of dollars in optimizing our building systems to capture every cent of insurance revenue, we can afford to invest in optimizing our relational system so that a scared patient does not collapse in the gap between our administrative silos. Before my daughter and I folded up the chaotic amusement park map, she pointed to a brightly colored path and said, let's go this way. She did not need a better piece of paper. She did not need a slicker, more colorful graphic. She needed me to take her hand, walk beside her, and guide her through the crowd. Our communities are asking for the exact same thing. We must stop funding passive information. We must stop pretending that publishing another brochure is an active health intervention. We must start investing in human infrastructure. The relational navigators, the community health workers, the trusted guides. We can meet people exactly where they are and walk them home. Because knowledge is just a map, but relational navigation is what actively changes outcome. Thank you for tuning into the Public Health Practice Gap. If today's conversation was valuable, please take 30 seconds to leave us a review on Spotify or Apple Podcasts. Share this episode with a colleague on LinkedIn, or join us inside the lab by subscribing to the Next Gen Public Health Lab on Substack. And if your hospital system, local health department, or nonprofit is ready to move past brochures and actively build human-centric navigation pathways, partner with us directly. Visit nextgenpublichealthconsultancy.com to schedule a consultation. And if someone you love is facing a serious illness right now, my new book, When Treatment Can No Longer Cure, is available on Amazon. The link is in the show notes. Let's stop printing maps. Let's stop building pathways. I will see you next Thursday. Let's get to work.